Today, the topic of our lecture is female pelvis imaging. Now, in recent years, female pelvic imaging has started to emerge as its own specialty. Like internal medicine is different from gynecology because gynecology is so different from medicine that it is considered its own specialty. In the same sense, the female imaging has started to become its own specialty, different from regular imaging. Because not only female anatomy is more complex, it is more prone to problems such as inflammatory diseases, autoimmune diseases, and all sorts of structural abnormalities. So, because of all of this, female imaging has started to emerge as a separate entity to regular radiology. But still, we do study it in the normal radiology because it is considered a part of it. Now, let's start with our lecture, and the lecture will start with acute pelvic pain in the reproductive age. Now, what do we mean by the reproductive age? It is the age of a female patient from her menarche to her menopause. Menarche is the start of the menstrual cycle. It usually starts around the age of 12 to 13 and can be as early as 11 years old to the age of around 60 when the menopause happens. That is the cessation of the menstrual cycle. Now, any pelvic pain during the reproductive age is categorized broadly into two subtypes. Either the patient is pregnant or the patient is not pregnant. So the first thing that is done in a female patient is to confirm if the patient has any type of gestation. So to confirm gestation, two things are done. One, beta HCG levels are done to confirm if there's any kind of pregnancy, regular or ectopic, or a detailed history and examination of the patient is also done to get a sense of the patient if she has any kind of abnormality, structural or physiological. So, like there's a difference between the patient, our choice of modality in order to choose for that patient, that changes with that. So the modalities are, for the non-pregnant patients, is the ultrasound. Now, for gynecological purposes or any kind of problem related to the female gender with non-gestation, ultrasound is the gold standard. It is widely used and it is the most widely used in the world. Why? 1, it is quick. 2, it is fast. 3, it is inexpensive. 4, it is becoming more and more portable. As you might recall, that fast is becoming more and more available in the emergency departments. So ultrasound is the gold standard for the initial diagnosis and examination and imaging of any patient with acute pelvic pain, but she has no symptoms or she has no signs of being pregnant. Now, ultrasound can be done via two routes. One is the transvaginal route and the second is the transabdominal route. Now, both of these routes have their advantages and disadvantages. Now, for the transvaginal route, the female adnexa are very much clear. They have more clarity to them, they are more detailed to them, but the peritoneal and the viscera of the patient are obscured. They do not have much detail in them. So in order to visualize them, we have to perform the transabdominal ultrasound. That will give us both an anterior view of the female adnexa and the peritoneal cavity. Now, let's suppose you have a patient who has lower abdominal pain, which is radiating to the right side and which is accompanied by the some kind of gynecological problem. Now, she might be suffering from acute appendicitis or she might have endometriosis. Now, in order to confirm both of these diagnoses, both of these ultrasounds have to be done because in patients with acute pelvic pains, one ultrasound is not sufficient because if you only do the transvaginal one, you might miss the inflamed appendix, but if you do the transabdominal one, you might miss if she has any endometriosis. So both of these have to be done concurrently in those patients. Now for the pregnant patients, those patients which show signs of gestations. Now in those patients, again, the modality of choice, the gold standard again, is the ultrasound. It is fast, it is quick, everything that I said before. But for some patients, for some problems, unenhanced MRI is also done. Now, unenhanced MRI is important because ultrasound usually is only for the detection of a problem. In order to confirm the problem or the mass or a disease or inflammation, the MRI is done. Now, you must take note that MRI must always be unenhanced, that no contrast media should be introduced to the pregnant patient because that contrast media will be extremely teratogenic for the patient. It will be bring harm to both the mother and the baby. Another modality that we use is the MR urography. Now, you might recall from my previous lecture that magnetic resonance urography is like a more advanced form of the IVU or the intravenous urography. In what we do is that we introduce a contrast media inside a patient and then we take a series of radiographs, and according to those radiographs we see both the patency and the focal lining of the urinary system. Now, contrast media cannot be introduced in the pregnant patient. So, for those patients, instead of doing an IVU, we perform its more advanced version, which is the magnetic resonance urography. It is both safe and it is both reliable. Now, here are some of the examples of images that I just said. Now, for the pregnant patient, as you can see, this is her bladder, this is the uterine wall, and this is the free fluid. Now, free fluid outside the uterus can mean a lot of things. Now, physiologically or in normal circumstances, after the ovulation, some free fluid is always present outside the uterus. So, it might be a normal occurrence. But for those patients with ectopic pregnancy, this might indicate something otherwise that will be seen in our next image. Now, this is the transvaginal ultrasound. As you can see that the first image the first thing that we see through the transducer is the uterus, and this is the cul-de-sac. Now cul-de-sac is also called the retrouterine pouch, or it is the space between the uterus and the rectum of the patient, and it is the one of the most common sites of ectopic pregnancy. And presence of fluid in this area is very much indicative of an ectopic pregnancy, even if you cannot find any other evidence of implantation, especially if that patient has high levels of beta HCG. Now, another thing that is very common in the pregnant patients, apart from the ectopic pregnancy or the normal fluid levels, is the, like I said, acute appendicitis, which can be done by performing both of the ultrasounds. Another thing that should be taken into consideration with the pregnant patient is the rupture of the placenta. Now, the abrasion of the placenta in pregnant patient is a very serious problem. Now, if the placenta has ruptured or there's some kind of abrasion with it, it must be diagnosed, it must be quickly handled before it becomes both fatal for the baby and the mother. Now we come for the non-pregnant patient. Now, if a non-pregnant patient complains of an acute pelvic pain, there can be a lot of scenarios. One of the most common scenarios that can happen is what is called Metastatic disease. Now, it is a very benign condition and it is present in about 20% of all females. Now, what happens at that in this disease, that there is an excretion of free serous fluid through the vagina, and it is considered normal, it is benign, and it should be considered that the presence of fluid inside the uterus is normal, because it can be both free and it can be enclosed in a cyst. Now, this is an example of a fluid inside the uterus. This is the endometrial cavity, and this one is the cyst. So, in non-pregnant patients, one of the commonest problems that you might encounter on an ultrasound is the presence of fluid. Now, that fluid can be both encased in a simple cyst, or it can be due to free fluid due to a Metastatic disease. Now, in non-pregnant patient, another cause of acute pelvic pain might be pelvic inflammatory disease, or it can be an ovarian torsion, or it can be hemorrhagic cysts. Now, hemorrhagic cysts are simple cysts or functional cysts which have undergone changes and have developed into hemorrhagic one, that they have started to bleed out, and these are the ones which are the most dangerous. Now, here is an image of a patient with this is the endometria, the uterine cavity, and this one here is the cyst. You can see some of the cyst is still intact, but all of this hypoechoic area here that you can see around the uterus is the hematoma because of the hemorrhagic cyst. Now, hemorrhagic cysts, again, like I said, they are very dangerous. They must be dealt immediately because they result in not only in vaginal bleeding, they might result in death. So this is a very typical example of a normal cyst or a normal functional cyst developing into an hemorrhagic one due to bleeding. Next, we have another very common cause of pelvic pain, that is the intrauterine device. Now, intrauterine device is a contraceptive device which is a T-shaped metal object which is inserted inside the uterine cavity. Now, what it does is that it allows the ova from the fallopian tube to flow outside through the vaginal canal along the menstrual fluid. Now, IUD is one of the more permanent and better solutions for contraceptions. But if they are allowed to stay inside the uterus for a long time, for more than what is recommended, they might result into both inflammation and then infection, and that infection will result in endometriosis, might result into pelvic inflammatory disease. Now, pelvic inflammatory disease is a very serious problem. Why? Because then it further complicates into either abscesses or infected cysts, or it might even result in hydrosalpinx. Now, hydrosalpinx is a common complication of PID, that is the pelvic inflammatory disease. And what happens is that because of either fluid, blood, or purulent substances, the fallopian tube is dilated. So, not only simple cyst or a functional cyst or a hemorrhagic cyst can result in pelvic pain, the presence of pelvic inflammatory disease or presence of a prolonged IUD implantation or even ovarian torsion can result in acute pelvic pain. Now, I must mention that ovarian torsion is not like the testicular torsion. It is not easily detectable. It is different from the testicular one. But one thing that is very common with the testicular one is that in both of these, the blood supply to the ovary is compromised. So if you see high blood flow towards the ovary that is not reaching it, just like in testicular torsion, it might be indicative of an ovarian torsion. So in this patient, as you can easily see, this is the transducer, this is the uterine cavity. Again, this is the lateral view. This is the intrauterine cavity, and this is the IUD. That is a metal tube, and because it is a metal tube, it is giving a very hyperechoic result on the ultrasound. Now, our next topic is abnormal vaginal bleeding and pelvic masses. Now, abnormal vaginal bleeding and pelvic masses can be due to a variety of reasons. It can be due to cysts, it can be due to and uterine fibroids, it can be due to tumors. There are a lot of reasons for it. But our choice of modality changes with each presentation. So, what are those modalities? These are the ultrasound, because in female anatomy, ultrasound is the gold standard, the modality of choice, because one, it is quick, fast, reliable. Second, it is portable. Another its feature is that it can be used in hard to reach places. Now, another one that we use is a contrast enhanced CT. Now, in patients in the previous topic, we did not use any contrast enhanced patients if the patient was pregnant. Again, here, if there are pelvic masses, if there are abnormal vaginal bleedings, and the patient is pregnant, contrast media is not used. But usually, that's not the case. We deal the patient with gestation in the other category. So a contrast enhanced CT will give a very good picture of what is wrong in the female pelvis. Next again is the ultrasonography, but this is the hydrosonography, in which what we do is that we introduced saline solution inside the female anatomy, and then we perform the ultrasound. Now, because of the filling of the saline solution, some of the especially the lining of the adnexa of the female anatomy is more visible, has more detail to it. Now, then we have the sonohysterography. Now, in sonohysterography, what we do is that again we fill the patient with, through a catheter, a balloon catheter with saline, and that saline filling can be done up to the fallopian tubes, and through the fallopian tubes it then moves into the peritoneal cavity. Now, if it is moving into the peritoneal cavity, it means that fallopian tubes are patent, they might be viable, and we can also deduce the structure of the uterus. It is a very inexpensive technique and can easily be done in a normal setting. Next, we have the MRI. Now, MRI has a huge role in patients with pelvic masses, because whenever a pelvic mass is diagnosed, now it can be confirmed on an ultrasound, but it is not usually done. MRI is the gold standard for confirmatory disease, for confirmation of the pelvic mass. Ultrasound is only used to locate it, to see its extent, to see its extent of the invasion, its infiltration, but MRI is the one that gives the definitive diagnosis of the problem. Another that we use is the PET-CT, or the positron emission tomography. Now, this one is exclusively reserved when we find a tumor inside the female pelvis, because PET scans are usually used to stage the tumor and to evaluate the chemotherapy and the radiotherapy that is done for that particular tumor. Now, our first example is of endometriosis. Now, here is an image of a patient with endometriosis. Endometriosis defines a condition in which the endometrium, the innermost lining of the uterus, is inflamed. Now, that inflammation can be due to some outside problem, or it can be due to an infection. Now, whatever that cause is, endometriosis usually results in filling of the endometrial cavity. Now, in this image, you can easily see that this endometrial cavity is showing the signs of endometriosis. The walls of the endometrium, they are thickened, they are inflamed, and you can easily see that it is also edematous. And this endometrial cavity is also showing an air fluid level. Now, this air fluid level is because of the presence of some kind of fluid inside the endometrial cavity, inside the uterus. Now, this fluid can both be purulent because of some infection, it can be mucoid due to normal endometriosis, or it can be debris of an hemorrhagic event due to an advanced endometriosis. Now, whatever the cause is, endometriosis usually results in excretion of fluid inside the intrauterine cavity, which can be easily seen in this image. Now, endometriosis sometimes presents in a focal manner. Now, whenever it presents in a focal manner, it develops into a very particular condition which is called an endometrionoma. Now, this is an MRI of a patient with an endometrionoma. Now, you can easily appreciate that this is the uterus, this is the endometrial cavity, this is the air fluid level, and because of this there is presence of an endometrionoma inside the patient. So endometrionoma is basically the outward invasion or infiltration of a focal endometriosis in a patient, or it can be also be described like a solid mass which has resulted from a focal endometriosis. And because of this, an endometrionoma has developed, and it has taken place of the normal fluid that is present because of the normal endometriosis, which can be easily appreciated in this MRI. Now, the previous image was of ultrasound nature. This is an MRI. Now, when I was explaining the modalities, I said that ultrasound is the first choice for whenever a mass or a problem is found inside a female patient, but it is never confirmed through the ultrasound. In order to confirm the diagnosis or any kind of suspicion, MRI is always done. This is a sagittal T2 weighted MRI of the same patient. Now, in this patient, endometriosis at this area has given rise to an endometrionoma, which can be appreciated here, and that has pushed the normal fluid inside the cavity outwards. So, endometriosis, a common problem which is very commonly seen in such patients. Next, we have the sonohysterography of a patient with fibroid. Like I said, abnormal vaginal bleeding usually results from pelvic masses, and one of the most common pelvic masses is either a fibroid or a tumor. This is an example of a fibroid, and this fibroid is being detected in this patient through sonohysterography. That is, the endometrial cavity or the intrauterine cavity is filled with saline solution, and because it is filled with saline solution, an acoustic advantage is given to the ultrasound, and because of this we can easily appreciate that this uterus has some kind of mass inside its walls. Now, this fibroid is of mural nature. It is very large and it has taken a lot of space. So such kind of fibroid can easily be found even on palpation on physical examination. But small fibroids are usually found either on ultrasounds, through sonohysterography, or through MRI. Only large fibroids are found, and fibroids are usually of benign nature. They do not pose any kind of a malignant potential. So this is again the saline filled endometrial cavity. This is the uterus of the patient, and this is the mural fibroid inside the uterus of that patient, which has given a bulge to the uterus. Next is the again a sagittal T2 weighted MRI of the same patient. Now, as you can easily see that this patient is exhibiting a lot of fibroids. So it wasn't just one fibroid on that ultrasound, there were multiple. But because fibroids are usually either hypoechoic or isoechoic with the uterine tissue, multiple or joint fibroids cannot be easily distinguished on ultrasound. They can only be distinguished on an MRI. So, a sagittal MRI has confirmed that this patient has not just one huge fibroid, she has multiple fibroids inside her endometrial cavity, inside her uterus. Next, we have the one of the most common problems that is encountered with patients with pelvic masses, that is an ovarian cyst. Now, this ovarian cyst is of normal nature, but we do not usually find ovarian cysts, simple ovarian cysts inside patients. We usually find patients which have cysts of complex nature. Now, in this patient, the cyst is towards the outside of the uterus. It has given a bulge, it has given a moral nodule, and this cyst is of simple nature. Now, sometimes what happens is that instead of fibroid, a very specific tumor may also develop inside the endometrial or the myometrial cavity, which is called a teratoma. Now, teratoma is a embryonic tumor that it gives rise to all kinds of tissue. It may give rise to hair, it may give rise to skin, it may even give rise to teeth inside the uterus of that patient. Now, all of these tissues can be appreciated when viewed through an MRI, but if the patient has a teratoma which is exhibiting signs of teeth development, that can be seen on a normal radiograph. So, this is a patient which looks normal, but here in her pelvic cavity you can easily see that there is a presence of teeth, and presence of teeth is always indicative, it is always confirmatory of a presence of a teratoma inside her uterus. Next, we have the again ovarian cysts. Now, the previous example of the ovarian cyst was of the simple type, but cysts are not simple. Usually, they are either complex or they are of the mixed type. This is an ovarian cyst with thick septations, which has given rise to a lot of different partitions inside and outside the bladder. Now, this cyst is huge, and this cyst must be dealt with immediately for the patient in order to both preserve the fertility, if it can be preserved at all. Usually, the course of action for such kind of ovarian cysts is oophorectomy, that is the removal of the ovary of the patient. Now, this is again the T2 weighted MRI of a patient with a ovarian cyst with thin septations. Now, if this cyst was viewed through an ultrasound, these thin septations might not have been visible. So, cysts with thin septations, with thin divisions, can only be viewed, can only be diagnosed, and can only be confirmed through an MRI, as it has been done in this patient. Next, we have an image of a patient with a solid mass. Now, this is a fat suppressed T2 weighted MRI of this patient. Now, this solid mass of the patient is exhibiting a very peculiar characteristic, that it is covered by fluid. Now, when solid masses are covered by fluid, they are usually indicative of a presence of a tumor. Now, this solid mass might be a benign tumor, it might be malignant, but usually solid tumors are indicative of a tumor. It might be benign, it might be malignant. Now, I might also mention here that cysts, the more complex they are, the more septate they are, higher they have the potential for being malignant. So, this solid mass, which is covered with the fluid, is a tumor, but it might be malignant, it might not be. But if it was a cyst, a complex cyst, a septate cyst, it might have potential of being malignant. Next, again, we have an axial CT of a patient with a solid ovarian tumor with omental caking. Now, omental caking is a term which is used in radiology when there is malignancy and when there is metastasis. Because whenever there's a solid mass and that mass is malignant, and because of its malignancy, there is metastasis in the omental tissue, in the fascia inside the peritoneal cavity, the metastatic tissue will give rise to small nodules, to small clumps inside the peritoneal cavity, which is called in radiological terms as omental caking. And omental caking is always pathognomic of being a metastatic tumor. So this ovarian tumor with omental caking is confirmatory of being metastatic malignant tumor. Again, I have a coronal CT scan of the same patient with omental caking all around the peritoneal cavity. Now, this is her intestinal tract, and this is the fascia and the omentum of the patient. Now, because of the metastasis, invasion and infiltration of the cells inside the fascia of the patient, inside the peritoneal cavity, it has given rise to both the clumping of the fascia and the omentum and the formation of the masses, which is termed as caking. So this is very usually seen whenever there is a metastatic disease. So these are the lymph nodes. Like I said, this is a metastatic disease, and whenever there is a metastatic disease, apart from the omental caking, you will find inflamed, enlarged lymph nodes. These inguinal lymph nodes of the patients, again, might be indicative of an metastatic disease. So in this lecture, we studied about First of all, acute pelvic pain in patients who are either pregnant or not pregnant. We learned that in pregnant patients, the choice of modality is different, and in patients with non-gestation, the choice of modality is very different. To sum it up, whenever patient is pregnant, contrast media is never used. CT scans are never used. Plain radiographs are never used because they contain ionizing radiation. They contain contrast media contains ions which are both harmful to the fetus and to the mother. Then we learned about different pelvic masses and its association with acute or chronic vaginal bleeding. So we learned about the different pelvic masses, what are its type, what are the cysts, what are its classification, what is a simple cyst, what is a complex cyst, how much malignant potential one has. We learned about the fibroids, we learned about the endometriosis, we learned about the tumors, we learned if a tumor has malignant potential or not. We learned about the term omental caking, that is the metastasis of a malignant tumor towards the fascia or the omentum in the peritoneum. So this was all learned and outlined in this lecture. Thank you for watching sqadia.com.